Bismillahirrahmanirrahim. Our lecture about peritonitis recording. Start by type of peritonitis to type, either bacterial or spontaneous peritonitis, in which pure infection occur, either streptococcal or pneumococcal or bacterial occur. Path of peritoneal infection, either gastrointestinal perforation or non-gastrointestinal perforation. Gastrointestinal perforation like peptic and divertical perforation. Non-gastrointestinal cause like pelvic infection, fallopian tube, exogenous contamination, female genital tract infection, and extra. Mortality of the patient with peritonitis depend on degree of and the duration of peritoneal contamination, age of the patient, general health of the patient, and the nature of the underlying cause. Next, localized peritonitis, either anatomical or pathological or surgical. Anatomical localized peritonitis, greater sac of peritoneum divided to either subphrenic, pelvic, and peritoneal cavity proper. Pathological depend on inflamed peritoneal loss, its glistening appearance, flake of fibrin, outpouring of serous inflammatory oxidate with leukocyte and plasma protein, peristalsis retarded and affected bowel vessel to prevent distribution, greater omentum and enveloping to become adherent to the inflamed structure. Surgical cause drain are frequently placed during operation as the localization of intra-abdominal collection. Next, another clinical feature of peritonitis is abdominal pain, worse on movement, gardening, abdominal pain, tenderness, pyrexia, rise pulse rate, absence of or reduced bowel sound, septic shock, systemic inflammatory response syndrome. Investigation or diagnostic aid of peritonitis depend on radiograph and serum amylase, ultrasound, peritoneal diagnostic aspiration, like bile staining or blood aspiration. This is the picture on table finding in case of peritonitis where the peritoneal cavity is filled with the pus, duodenal perforation, and ileal perforation with severe peritonitis. This is X-ray show the air under diaphragm and other severe peritonitis showing the pus in the peritoneal cavity, perforation of the fundus of the uterus to attempt abortion. It causes severe peritonitis. Management of the peritonitis, either general care of the patient, correction of the fluid, insertion nasocutaneous, broad spectrum antibiotic analgesia, and vital systemic support. Abortive management or treatment depend on the cause of the peritonitis, either perforated of the appendix, peritoneal debridement, lavage, and accordingly, with use of large amount of the saline for wash of the bowel or the intestine or the cavity of the peritoneum with antibiotic cover like tetracycline dissolved in normal saline. Complication of the peritonitis, systemic complication like shock, endotoxic bacteremic shock, bronchopneumonia, renal failure, bone marrow aspiration, multi-systemic failure. The other abdominal complication of the peritonitis, ileus and adhesion of the small bowel, residual recurrent abscess, and portal bimae liver abscess. Clinical feature of the abdominal and pelvic abscess formation follow the local or diffuse peritonitis. Symptom and sign of perineal collection may be vague and consist of the malaise, anorexia, pyrexia, sweating, tachycardia, leukocytosis, abdominal pelvic pain. Symptom from local irritation like hiccup and diarrhea. Pelvic abscess, the causes of the pelvic abscess, the common site for the intraabdominal abscess because the vermiform appendix, fallopian tube, pelvic abscess occur sequel to any cause of diffuse peritonitis. Clinical feature: the most characteristic symptoms are diarrhea and passage of the mucus in the stool. Rectal examination reveals bulging of the anterior wall of the rectum. Treatment: start by conservative management, antibiotic, a proportion of these abscesses. Rest, pass into the rectum, after which the patient nearly always recovers rapidly. If this does not occur, the abscess should be drained directly. Mandatory. In women, vaginal drainage through posterior fornix. In the other case, which the abscess is definitely pointed into the rectum, rectal drainage is employed. If any uncertainty exists, the presence of the pus should be confirmed by ultrasound or CT scan guide. Laparotomy is almost never necessary in pelvic abscess. Rectal drainage of the pelvic abscess is far preferable to suprapubic drainage. Drainage tube is also inserted percutaneously through or the vagina or the rectum under ultrasound or CT scan guide. Subphrenic space or subphrenic abscess. Clinical feature: there is a rule or in pus subphrenic, pus somewhere, pus nowhere else, pus under diaphragm. طبعا هاي مقولة مشهورة يعني معروفة about the collection of the pus. History relevant to the specific cause history of any previous surgery, fever. This is important. Child rigor depend on the cause of the subphrenic abscess. Tachycardia, collapse, hiccup, tachycardia, irritation of the phrenic nerve. Patient come with hiccup and tachycardia. There is a sign, hover sign, scoliosis toward the same side of the subphrenic abscess. Wasting anorexia is common. Occasionally tender mass in the right hypochondrium may be palpable. Bacterial causing of the subphrenic like E. coli, Klebsiella, streptococcal, anaerobic organism. Other different diagnosis of the subphrenic abscess: amoebic liver abscess, pyelonephritis, empyema, and pulmonary collapse. Investigation: as mentioned previously, plain chest X-ray, chest, abdominal show soft tissue shadow, pleural effusion, fluoroscope, and ultrasound. This is mandatory. High C-reactive protein, CT scan, and other of investigation. Management or treatment start with antibiotic ampicillin, triple antibiotic ampicillin, trandazole, and garmycin or cephalosporin. Percutaneous drainage under ultrasound and CT scan guide. Aspiration alone is not done in subphrenic abscess, must be done under antibiotic cover. Open drainage indicated if there is symptom persist and when it abscess increase in size and there is thick pus, multiloculated, or failure of the conservative management and contraindication for catheter drainage. And multiple abscess present with the foreign body. This is all indicated for open. This is the diagram. Show the left subphrenic, right subphrenic, subhepatic, left and right. This is the causes of the subphrenic abscess: appendicitis, periodontitis, splenectomy, pancreatitis, and other surgery, gastrectomy, biliary surgery, and pelvic surgery. Common cause of subphrenic abscess. Special form of peritonitis in post-operative peritonitis. The patient is ill with raised and pulse and pelvic circulatory failure. Local symptoms and signs are less definite. Abdominal pain may not be prominent because the patient have surgery. Treatment: an antibiotic therapy and alone is inadequate, and surgical operation. Peritonitis in patients with treatment with steroid, pain is frequently slight or absent. Physical sign is vague and misleading. Peritonitis in children, the diagnosis may be more difficult, particularly in the preschool child. Physical signs should be elicited by gentle patient and sympathetic approach. In patients with dementia, such patient can be fractious and able to give reliable history because the patient dementia. Abdominal tenderness is usually well localized and rigidity are less marked. Bile peritonitis, cause of bile peritonitis, to the most common causes were perforated cholecystitis, post cholecystectomy, cystic اللي could be cystic stump, يعني يصير slip leakage from the axillary duct, bile duct injury, and T-tube dislodgement. Following other operative procedure, injury from other procedure like longitudinal stump injury, post-gastrectomy, bile and enteric anastomosis leakage around the percutaneous place of biliary drain. Following liver trauma. TB peritonitis or tuberculosis peritonitis, it is acute or chronic abdominal pain. Patient come with abdominal pain, caseating peritoneal nodule, ascites, or intestinal obstruction. Origin of the infection could be from mesenteric lymph node, could be from the ileocecal, or biosalpinx, or bloodborne biliary tuberculosis. Variety of the tubercular peritonitis, four variety, either ascites, could be patient come as ascites or cystic, or fibrous, or come with purulent. Neoplasm of the peritoneum, carcinoma peritonei, the main form of the peritoneal diseases are discrete, could be discrete nodule or plaque, varying in size or in color, or come with diffuse adhesion from this form occur at late stage of disease and give rise sometimes frozen pelvis. Different diagnosis, tubercular peritonitis and fat necrosis, peritoneal had a cyst, especially after rupture had a cyst and seeding of the daughter cyst. Treatment, ascites by symptomatic and intraperitoneal chemotherapy, endocrine therapy in the case of the hormone receptor positive tumor. Pseudomyxoma peritoneal, this is the rare condition occur more frequently in women. The abdomen filled with the yellow jelly large quantity in which often insistent. It is associated with the mucinous cyst tumor of the ovary and appendix. It's often painless and there is frequently no impairment of general health. It does not give rise to extra peritonitis. Diagnosis is more suggested by CT scan and ultrasound and made at operation. Treatment at laboratory, usually associated scoped out appendix fibrillation should be excised. Recurrent is inevitable يعني حتمي. Patient may gain symptomatic benefit from the repeated operation debulking surgery. Occasionally the patient responds to radioactive isotope or intraperitoneal chemotherapy. Mesenteric cysts are classified as either chylomymphatic or simple mesothelial and enterogenous or dermoid or urogenital remnant. Feature of mesenteric cyst either painless abdominal swelling, a recurrent attack of the abdominal pain with or without vomiting, an acute abdominal catastrophe with rise as a result of torsion, could be rupture of the cyst or hemorrhagic in the cyst or infection of the cyst. Diagnosed by ultrasound, CT scan, barium, meal, follow through accordingly. Management, treatment of the mesenteric cyst, many chylomymphatic cysts can be inoculated in toto or aspiration of the content of the cyst. This is chylomymphatic cyst and enterogenous cyst. And thank you for all.